again? Oh, I'm gonna go. Professor Keller, did you have it? No. Is it yeah.
That's better. Tell them stay off of that. Camera's right.
Good morning, everybody. We just want to welcome you on behalf of CNHS to our symposium. My name is Stephanie Reyna-Bones. I'm the program coordinator for the Communication Sciences and Disorders program. So our students are studying pre-speech pathology, pre-audiology, after this, these things. And so this morning, you're going to have the privilege to hear some hard work. There are 3 of our students who are seniors this year will be presenting. And first up, we have Isabella Gleason. I'm going to introduce her, and then she's going to come stand right here, and I'll give you the clicker, and you'll take it away. We do have people watching online today, so welcome. Isabella is majoring in communication sciences and disorders with a minor in neuroscience and psychology. She's from Tampa, Florida. She has her parents and I think a grandparent here today, so welcome. And she has volunteered at LRH in the trauma department, has been an academic tutor, and is a member of our club on campus. After graduation, she plans to pursue a PhD in clinical psychology. So welcome, Isabella.
Can we hold you up for just a minute? I'm bringing some of my students. We were at Dr. Franklin's book.
No worries. Come on in. And if you stand right here.
Yep, it's getting like from that end to here.
Like there's no ceasing. Oh gosh, somebody's pulling me. Yes, it's high school students are standing on the pole outside. Sorry, thank you for your patience. This is real presentations where stuff goes wrong. Okay, let's quiet down so she can start.
Good morning, faculty, students, friends, and family. I hope that you are all doing well. For my research, I'm proposing a method for analyzing the cognitive effects of Chiari malformation type 1 and their progression following cerebral toxin reduction. So before we can understand, we need to know that Chiari malformation is a brain malformation, and we need to look into something called the little brain. So we all have little brains, and our little brains are actually really important in how our body works. And if you look over to the bottom of the picture, the cerebellum and the tonsils are actually what makes up the little brain. Our little brain is responsible for so many different things in our body, from motor control and balance to muscle tone and cognitive functioning. So when something happens to this little brain, then the body is impacted. The brain malformation I'm studying has multiple different types, and I'm going to be focusing on type 1. There are a few different that they present differently in the human body, and they have different effects. So for example, type 4 is not compatible with life, but type 0 only presents with headaches. So Chiari malformation type 1, or CM type 1, is a neurological disorder where the cerebellar tonsils, or the little brain, herniate into the cervical canal by 5 millimeters or more. So if you take a look at image B, this is a healthy individual, and if you can see the white line, that the brain should not be going below this white line. In image A, this is somebody with a brain malformation, and the bottom of their cerebral tonsil, or the little brain, is going down into the spinal canal. This creates a lot of issues in the human body and leads to something called stringomyelia, which is the blockage of normal cerebral spinal fluid. And this fluid is important for the cushioning and protection of functions in the brain and in the spinal cord, and it actually causes cavities in the spinal cord. So as that sounds like it has a lot of consequences, it affects impaired cognitive functioning, it affects memory, it affects motor control, it can cause head and neck pain, difficulty swallowing, and respiratory failure. So because this is something that really impacts the quality of life for people and affects how they function daily, it's important to look at surgeries to help solve this. There are two main treatments that are being recommended. The first one is posterior fossa decompression, which is removing a piece from the base of the skull to make more room for the brain. And the second is cerebral tonsil reduction, or CTR, and this is the shrinkage of the little brain. That one is the one that I'm going to be focusing on for my research. Something interesting to take note of is that in literature, because of the function of the little brain, shrinking it, which is supposed to help these patients, might actually produce more side effects for them, which is why it's important to see what might come up. So the precise cause of this disorder is not known. There are a couple of different proposed theories, such as hydrocephalus, or the pressure coating theory, or quadrant traction and posterior fossa overcrowding, which is a fancy way of saying that the skull is just too small for the brain. The complexity of this disorder cannot be determined by one cause, and it differs from case to case. CM type 1 is rare. It occurs in 0.9% of the adult population and 0.6% of the pediatric population. It's most commonly observed in women from ages 30 to 50. It's primarily diagnosed through MRIs, which is a magnetic resonance imaging, and then it's followed up with neurological exams such as cranial nerve assessments. A fun fact about the diagnosis process is that 14 to 21% of these cases are discovered on accident. So if somebody comes in with a headache, or if they're in a car accident and they need an MRI, then sometimes they find out that they have this additional malformation going on. So why is it important to research this brain malformation? There is a current lack of research as to the long-term cognitive effects of this malformation, which helps to determine patient quality of life. So patients are having this surgery and they're having unknown outcomes, and they're not getting the results that they expect. So for this research aims to address this gap by examining how areas such as attention, executive functioning, memory, emotional processing, and communication skills may improve, decline, or keep these domains consistent. So with that, the question that I was aiming to answer is, how does cerebral tonsil reduction, CTR, surgery affect the cognitive function in CM type 1 patients over time as measured by standard neuropsychological assessments? So in order to answer that question, I proposed a framework for analyzing these cognitive effects. In order to do that, I had to suggest assessment boundary. I had to come up with an optimal timeline for administration and for an effective statistical analysis. The patients that I'm looking for in my study are adults aged 18 to 65 who have been diagnosed with this brain malformation through an MRI. They have to be scheduled for the cerebral tonsil reduction and no other surgeries. I'm hoping for a target size of approximately 30 people. There are some exclusion criteria enabled to keep the results consistent. So if anyone has had pre-existing medical conditions, disorders, or prior surgeries for this malformation, then they will not be included in this study. The protocol is a neuropsychological assessment battery, as I mentioned, going to be administered by both a neuropsychologist and a speech-language pathologist in accordance with a proposed timeline. Following that, once the data is collected, it will be analyzed by a statistical analysis called ANOVA. So this is the neuropsychological assessment battery that I made. There are 5 different tests that are going to be administered, and each target either one or multiple of the cognitive domains. So the first one is the TMT, which targets both attention and executive functioning. The second one is the WCST, which targets executive functioning more in the area of cognitive flexibility. The third is the RAVLT, which targets memory skills. The MSCEIT, which targets emotional processing. And last is the CADET, which targets communication skills. So this last one, the CADET, is the one that's going to be administered by a speech language pathologist, and the rest will be administered by a neuropsychologist. In order to get the most accurate results, there's a proposed timeline for these administrations. I would like the patients to be given the battery by the professionals 4 to 6 weeks before surgery. This is going to help to give a pre-surgical baseline for where they are. After that, 1 month after surgery, I would like them to retake the same battery they took and give an early post-surgical outcome. So where are they and where might they be projected to go? They're going to take the same assessment battery at 6 and then at 12 months. At 12 months, it's going to be the final assessment, and this is going to determine the trajectory of long-term cognitive outcomes. So once the assessments have been administered for all 4 times, the data will be collected and then it will be analyzed using, as I mentioned, ANOVA. That is a repeated measures of analysis of variance. So this compares cognitive performance across 4 different time points. It helps to evaluate the effectiveness of the surgery on those different cognitive domains that I mentioned. So after the data has been collected and it has been put into an ANOVA system, it is going to be found these different mean variables for each of the 4 different assessments. From there, standard deviations are going to be found to help assess variability and establish consistency. Because the surgery itself is likely to produce different outcomes because you're shrinking the brain, some outliers are expected to be detected, and they will then be analyzed to conduct and realize the impact of them and see if they should be included or excluded from the study. So the expected results of this study. All of the 5 different areas are likely to have a little bit of improvement, but it's not guaranteed. So it depends from patient to patient where they're going to be after they have the surgery. Some patients may experience decline, but in every single area, there should be a little bit of improvement. When you look at communication specifically, because of the location of the little brain, when you shrink it, it's likely to cause swallowing complications, which could in turn affect the patient's speech and communication abilities. This is important to keep in mind because if patients come out of a surgery and now they're not able to talk as well as they used to or function in that way, the doctor can have the information already to refer them out to speech language pathologists or professionals to help them. So why is all of this important? What do we do now that we have data? The results can help to influence treatment decisions for these patients. So there are a couple different treatment options that they can pick from. And now that they have more information on this one specifically, they can know if it works best and it's most suitable for them. It can help to establish potential trends and outcomes. It can provide insights for monitoring and adjusting protocol for doctors. It can help the identification of where patients need additional support. So as I mentioned, speech therapy for communication. It can set realistic expectations for families and parents. And most importantly, it can increase patient education. So once they're putting themselves through this procedure, what should they expect to happen to them? Areas of future research include long-term tracking. So the timeline that I proposed goes up to 12 months following surgery. If you do a long-term longitudinal study and see the results over a multi-year period, you can see if there's more variability or consistency in these results. Additionally, a cross-analysis between the efficacy of cerebral tonsil reduction and other procedures. So then patients can have more education on the results of their surgery versus other surgery options. And then another area is the correlation between physical improvements and cognitive functioning. So because the little brain is responsible for motor control and muscle tone, having physical improvements might help areas such as emotional processing. And in conclusion, research shows that some individuals who undergo surgery continue to experience persistent symptoms. So that highlights a need for more investigation into this area. And that's the purpose of my study, which aims to refine treatment strategies, pro-surgical care, and patient education. It explores the need for different therapies that might be needed to address issues, and the overall goal is to improve quality of life for these patients. I wanted to say thank you to my friends and family and all the faculty and staff that I've had at my time here at Southeastern for making it so special and for pushing me to be the best student I can be. But most importantly, I wanted to thank God for the blessings that he gave me and the ability that I have to come up here and to educate and to research and to help people and serve his kingdom. So I'm
Any questions? I'll throw out a few. So these patients initially, they're CM1,
Yes.
correct? So what were the symptoms initially that were associated with that? I know that you said it as you went through the levels.
Yes. So headaches, neck pain, difficulty in daily functioning, difficulty with movement. It's actually often misdiagnosed as chronic migraines or as other conditions because of the commonality of the symptoms.
So the proposition is to study people who have symptoms, right? This wasn't an incidental finding in those cases,
Yes.
right? You said that they could, whether or not they would choose this or other surgical option. What other surgical options are there?
So another one that I had mentioned is the posterior fossa decompression. That one is the more common surgery, and that's removing a piece at the base of the skull. And then there are a couple other surgery options and like therapeutic therapies that can be done. But in order to alleviate the issues with this surgery is the most needed outcome.
And what made you choose this topic?
That is a great question. So one of my professors actually had this condition, and she had this specific surgery, which is why, even though it's less research, I chose to focus on it. And she went through and she had the surgery, and she told me, she's like, I had the surgery and I wasn't able to speak as well as I used to be able to, but the doctors didn't tell me that I was going to have trouble. So that kind of opened my heart for, people are going through this and they're coming out and they're confused about why they're not functioning how they used to.
Good. Thank you. You're awesome. You did a great job.
Yes.
This is more of a clarifying question. So for the NOVA test, you need 3 or more groups.
Mhm.
And so are your groups are going to be timelines and not separating out your patients into 3 groups?
Yes.
Okay, so each time.
Mhm.
Okay.
Anyone else? Yes.
So in the causes of it, what's the pressure code?
So the pressure coding theory, all of those are just fancy ways of saying that there's too little room in the brain. So the skull is too small to house the brain. So it pushes it down into the spinal cord or hydrocephalus, so other conditions that might cause a malformation or abnormality in the brain. Yes.
What is the percentage of that surgery being, percentage of which surgery is done now, like the posterior fossa versus the CTR being done?
I would say percentage-wise, majority is the posterior fossa decompression, probably 70, 65 to 30. This one is a lot less studied. There's a lot less literature in the field on it, which is why I think it's so important to research it more. But it's definitely majority of the other surgery.
Do you know what determines why they choose one surgery over the other?
Yes, this one is a little bit more risky because it involves the shrinkage of the brain itself versus the other one that's just creating more space. So because this one is shrinking the brain, it's going to cause other issues in the body.
Why do you take the risk?
Because sometimes, given the structure of the human body, it might not be the best option to remove part of the brain. And sometimes shrinking it is just the best option depending on the patient and the severity of their case. Anybody else?
Oh, what is he doing now? What are you up to? How old is he now? 8 months. Rolling, getting ready.
She's so close. He gets so frustrated.
Does he rock?
He's rocking and he'll face plant out the ground. That's crazy. He'll climb all over me and you're so close. Yeah, he's funny. Go to the menu up top, left. Keep going up. There we go. And then view. or just like?
You?
Yes. And then full screen. So I guess control out. Now we know.
All right.
Oh, yeah. It's at the form.
There's 24 seats up here. If you guys want to have a seat, you can.
Do you want to click out of the need to fill out just so it doesn't block me? It won't go away.
Oh, okay.
Oh, there it is.
All right. Good morning again. Welcome to the new group. This morning I have the opportunity to introduce Hildalie Gonzalez Picon. I didn't practice before, I apologize. Hildalie is majoring in communication sciences and disorders. She's from Lakeland, Florida, and she's been at SU for 1.5 years. While at SU, she's mentored for the LINK program. She served as a TNA for CNHS. Thank you. We love for help. And she was a part of the Initial Club. After graduation, she plans to go to graduate school to study speech pathology. Welcome to Hildalie.
Good morning, everyone. So the question that I have established for my research is, in bilinguals with aphasia, can a cultural stimulus support their semantic network? I would like to start off with some current statistics. In the United States, there are over 67 million people that speak another language. Spanish is the most common non-English spoken language in the United States homes with a 62%. ASHA, which is an organization that provides credentials to speech language pathologists, audiologists, and communication experts, have revealed that there's over 200 members that provide services. Out of that amount, only 15,728 speech language pathologists provide multilingual services. Strokes are the leading cause of death in Americans, as well as the leading cause for long-term disability, and is also known for the most common cause for aphasia. Aphasia is a language communication disorder that impairs your production for speech, language comprehension, and your ability to read and to write. Some of the causes for aphasia are brain abscess, brain injuries, brain tumor, strokes, and damage on the left side of the brain. Aphasia is usually grouped into two different areas. It can either be fluence, meaning speech production can still occur, however, it does not always mean that the speech will make sense, or it can be non-fluence, meaning speech production is impaired, but they have a better chance of their language comprehension being in function. Two of the most important areas for speech production are Broca's area, which is in charge of speech production, and Wernicke's area, which is in charge for language comprehension. There are several types of aphasia. For this specific study, I will be addressing anomic aphasia, which is on the far end of the chart. This chart was created by the National Aphasia Association to help distinguish the characteristics of each. So for anomic aphasia, it is fluent, so speech production can still occur. The person can comprehend messages spoken to them, and the person is able to repeat words and phrases. Anomic aphasia is a mild form of aphasia. As stated previously, it's still fluent, well-articulated, grammatically correct, and the auditory comprehension is intact. However, they can't come up with words. They have an impaired word retrieval. Some characteristics that describe anomic aphasia are slow speech and circumlocution. Circumlocution is when a person is speaking around a word because they can't come up with the word themselves. There's no cure for anomic aphasia, so speech therapy is usually used to help treat this kind of anomic aphasia. This image is an overlap of 37 patients with anomic aphasia. Lesions span across the left side of the brain, so there's no specific area in the brain that defines where anomic aphasia occurs. For this study, I will be addressing bilinguals with aphasia, specifically bilinguals that speak Spanish and English. Bilinguals with aphasia have both of the languages impaired, and both of the languages follow different recovery patterns. Several case studies that have taken place have been able to provide treatments in both of the languages. Through other case studies, they have been able to see cross-language generalization across patients. Cross-language generalization is when skills are learned or trained in one language that are capable of transferring over into the untreated language. However, there's no consistent patterns, and further investigation is needed to prove that this can actually occur. As stated previously, there's not many bilingual speech therapists. However, the next recommended thing would be to include an interpreter into the assessments or treatments. However, a recent survey of speech language pathologists and interpreters on collaborative assessment in aphasia have revealed that there's a lot of miscommunication across both professionals, as well as there's a lack of understanding for the goals of the patients with aphasia. Another challenge is that there's a lack of culturally and linguistically relative materials to help assess and treat. And this was revealed through a scoping review that not only included speech language pathologists, but that also included physiotherapists and occupational therapists. Another thing is that there's limited treatment for bilinguals with aphasia, and several case studies have indicated that a personalized treatment can help with a bilingual that has aphasia. So the purpose of this study is to measure the effects of a cultural stimulus on bilinguals with aphasia. There will be two groups that will receive the same type of intervention. However, one group will receive a cultural stimulus, which is a questionnaire that will help personalize their treatments, and another group will not receive this cultural stimulus. The following questions will be addressed for my study. Will a culturally relevant stimulus create a difference in the retrieval of words in bilinguals with aphasia? And will there be any improvements in the untreated language for both groups? To be part of the study, bilinguals with aphasia must have received a recent diagnosis on mild aphasia, have not received any treatment from a speech language pathologist, and must be able to speak fluent Spanish and English prior to having acquired aphasia. Spanish has to be the first acquired language, and they must significantly identify with a culture. The study will go as follows. The bilingual aphasia test will take place for every participant to set the baseline. And then the cultural questionnaire will be provided to one group, which will help personalize their treatments. Following that, both groups will receive the same type of intervention called semantic feature analysis, which I'll be addressing in the following slides. And the treatment will only be provided in English. There will be a total of 5 semantic categories addressed for this study, given that it's recommended to have a moderate amount and increase if there's improvements with participants. Every week, a new category of words will be introduced, and for every category, there will be 10 words that will be targeted. Based on those 10 words, there will be an assessment to see the progress of each participant. This will be provided for 3 times a week for 30-minute sessions. The study will last for 5 weeks. And at the end, the bilingual aphasia test will take place. And this is a timeline for both groups. The only difference is that one group will receive a cultural stimulus. Every week, they will receive a new semantic category, as you guys can see. So the bilingual aphasia test is a culturally and linguistically assessment that is available in 60 different languages. It consists of 3 different parts. The first part is the history of bilingualism. So they will ask questions of when the first language was acquired, when the second language was acquired, and what language they are most dominant in. Following that, there will be different subtests that will test on the language structures such as fluency, naming objects, sentence production, and repetition of tasks. And it will end with an assessment of translation in both directions, giving language pairs. And this will be done through reading tasks and writing tasks. This is just to help see if they understand both languages. Not only is this used to help assess, but it's also used to see if a treatment is effective. So the semantic feature analysis is a type of intervention that will be provided for both groups. It was created by Harbauer Kupa back in 1985 to help individuals with traumatic brain injury in the search of their semantic memory and episodic memory. Everyone has semantic memory, and this consists of knowledge of the world, things that we've learned throughout our education, names, locations, and general facts. Episodic memory is based on personal experiences, and both the semantic memory and episodic memory work in hand to help us retrieve words when we're speaking. Semantic feature analysis is an evidence-based practice that has been used effectively across patients with aphasia, and it has also been used in bilinguals with aphasia. So when they're receiving this type of intervention, an image is shown, and the first thing that they're supposed to do is to name the image. If they can't do that, they are then prompted with cues or questions to help them retrieve that word, such as the properties of the image, the association to the image, the location of the image, and actions towards the image. So for the cultural questionnaire, with the help of a family or friend, they are to list 10 words for every category that will be introduced for this intervention. Those 10 words listed on each category can relate to their culture or traditions. The idea is that these images will then match the images shown in their. So the expected outcomes of this study, there will be improvement in the treated language. However, it's hard to say that there will be improvements in the untreated language because that every participant's language dominance is different, either in Spanish or English. The cause for aphasia for every participant will be different. And the Spanish spoken by every participant is different. Every Spanish is different based on the country and region. So all of those things could affect the results of both groups. However, it is presumed that the group receiving the cultural stimulus will have a higher chance of presenting cross-language generalization, given that the intervention was more relevant to them. For future studies, there's a need for bigger group studies. A lot of the information I was able to find were single case studies or had a limited amount of participants. And there's more studies needed to address more languages. And there's need for better methods to prove that cross-language generalization can actually occur. Those are my references. And I would like to just thank God for the opportunity to give me to learn through this study, as well as my professors here, Professor Renovales, who has been a great blessing as well, my classmates and family and friends. Are there any questions?
So I'm just not sure that, I just want to make sure I understand. I know that you said it. So they're bilingual, their predominant language is English, even though they learn Spanish first. Is that
Yes.
what you're saying? So the treatment is in English.
Yes.
Okay. Yeah, I just wasn't sure. I thought that's what you said.
And why did you choose that as the treatment language?
The reason for that is because it's one of the most common languages spoken in the United States, and I wanted to target that demographic as well. Yes.
Can you go back to the hot chocolate picture?
Oh, down.
So for people who don't know what that is, like how the test is given, can you give an example of like if a patient pulled out that they don't know what that is, what other image then would you use to help them?
So we want the treatment to be relevant to them. If they don't recognize that, we want to also be culturally adaptive to where they're from. And that is why I created the cultural questionnaire, because that will see if the treatment is relevant to them.
Right. So for example, someone from Mexico who makes like authentic hot chocolate, they melt the chocolate. Would you use a picture then of like actual melted chocolate versus that picture of hot chocolate because they don't know what that is?
Yes.
Okay, so that's what makes it culturally responsive to that. Okay, got it.
And they don't answer all 5 of those questions. It's just if they can't name it, then it goes to the next level, right?
Right. Yes.
And just clarify, because I think it's really important. It's because of the reason you chose English as the treatment language is because of the disparity between therapists who actually speak a second language and the majority of therapists speak English. So you're going to see if treatment in English could actually generalize to their primary language, which would be Spanish, but you're going to treat in English.
So we want to support monolingual therapists as well.
So clarify. Thank you. Anybody else? Thank you. Thank you guys for your enthusiasm. Our students have worked really hard. And last but not least, we have Catherine Morsberger. She's majoring in communication sciences and disorders. She's originally from Maryland, but now lives in Tampa with her family, and she's been at SU for 3 years. While at SU, she's been a part of the Light Girls Ministry and has been an RA. She plans to study abroad next semester and is hoping to attend seminary to pursue a degree in counseling after graduation. So welcome back.
Hello everyone, thank you for joining me. Today I will be presenting on how feeding and swallowing difficulties in preterm infants correlate with their growth and neurodevelopmental outcomes. This is a critical topic because it addresses some of the most common and challenging issues faced by preterm infants, and it highlights the importance of their research to improve their care. Today I will walk you through these common challenges and gaps in their research, as well as a proposal to improve and bridge those gaps. Before we dive into the content, I'd like to bring your attention to this picture. This is an image of a preterm infant in a neonatal intensive care unit, or a NICU. You can see that the baby is hooked up to some life-sustaining equipment, including a nasogastric tube, which delivers nutrition directly to the stomach. Full-term babies typically develop the ability to feed without assistance late in pregnancy, but preterm infants do not always have that specialty and that ability. They often require this type of support to meet their nutritional needs. But while this tube is essential to their survival, these early challenges often can have lasting impacts on their growth and development, which we are going to look at today. So just as an introduction, preterm infants face significant challenges due to their underdeveloped neural and muscular systems. These challenges make it difficult for them to perform basic feeding functions like swallowing, sucking, and breathing. These feeding issues not only affect nutrition, but they also can delay their physical growth and development. This impacts their motor, cognitive, and language development. And while many studies focus on the short-term outcomes, we need more of the long-term impacts. Additionally, without standardized assessment tools, it's hard to identify these early signs or provide consistent interventions. So we'll be exploring these challenges and ways to address them. Feeding difficulties in preterm infants is widespread and often severe. Common challenges include choking, gagging, and aspiration, which is when food or liquid enters the lungs instead of the stomach. These issues occur because preterm infants lack mature oral motor systems, making it difficult for them to coordinate and perform essential feeding functions. This often necessitates the use of a feeding tube, as seen in this photo, to ensure that they receive adequate nutrition. These challenges can contribute to poor weight gain, respiratory complications, and delays in motor and cognitive development. Feeding preterm infants is truly a journey. It begins with tube feeding, as many infants are not yet ready for oral feeding at birth, but they will eventually transition into bottle feeding or breastfeeding. But this transition is a journey. It requires 4 steps. And the first of those is early intervention from feeding specialists to guide families and monitor their progress. Second, a gradual approach is critical, starting with small volumes and increasing slowly as well. Third, patience is key, as these infants need time to develop necessary skills. And finally, close monitoring helps to track weight gain, detect aspiration, and ensure safe feeding. And each of these steps is essential to feeding to allow these babies safer and more effective feeding skills to help them reach critical and developmental milestones. Now, there are 3 major challenges in researching feeding and development in preterm infants. First, the longitudinal studies rarely extend beyond 2 years, or toddlerhood, and infancy, newborn toddlerhood, which miss really the critical development stages like adolescence, and which is really where the delays may become more pronounced. Second, we lack standardized assessment tools to assess feeding and neurodevelopmental outcomes, which make it difficult to identify early signs or issues to monitor progress across different healthcare settings. And finally, in intervention effectiveness. Interventions are primarily focused on infancy with minimal support and research as children grow older, similar to the longitudinal studies. But this creates a long-term gap in care, and it really raises the question of who ensures that these children get the support that they need when early interventions end. This timeline here highlights the classifications of preterm birth. Infants born before 37 weeks are considered preterm, with those born before 28 weeks considered micro-preterm. The earlier that an infant is born, the more likely they are to face severe feeding issues due to their underdeveloped systems, as they miss critical weeks in the womb where feeding and swallowing reflexes develop. My proposed study focuses on preterm infants with oral motor difficulties, aversions to eating, or parental feeding challenges. These challenges often necessitate the use of a feeding tube, as mentioned earlier, and require close monitoring to understand the impact on growth and neurodevelopment. Feeding difficulties impact growth in three main ways. The first of which is poor feeding efficiency can delay weight and length gain. The second is that transitioning from tube feeding to oral feeding can take much longer in preterm infants, limiting nutrient intake. Lastly, severe cases can result in growth faltering, where infants fall below critical percentiles on growth charts, which is seen in this visual. This graph plots growth metrics of weight, head circumference, and length across completed weeks of gestation. The color-coded lines represent different growth percentiles, with the lower percentiles indicating at-risk infants. Those who fall below the yellow line, which represents the 10th percentile, are considered at risk for growth faltering, and they need intervention to address feeding and nutrition issues. This allows us to see how preterm infants often do fall below average percentiles in critical areas, reflecting the impact of early birth on their physical development trajectories. So my proposed study to you today is a retrospective analysis of medical records of preterm infants with documented feeding challenges. By examining growth charts, neurodevelopmental assessments, and other long-term outcomes, this study aims to identify patterns and correlations between feeding difficulties and developmental progress. A retrospective design allows us to analyze existing data, providing insights into trends without requiring any new data collection. There are three projected outcomes with this proposed study, and that is in the fine motor delays and feeding type, the link between growth and neurodevelopment, and in their implications for intervention. And to say this in a way where they all kind of make sense, feeding type is not just about nutrition. It, as I've mentioned extensively, it directly affects motor skills and motor skills like how babies bring food to their mouths or how they grab their toys. These abilities are building blocks for later development. So when they're delayed, it often signals bigger issues like slower brain growth or motor growth. Additionally, by using fine motor delays as an early indicator, we can step in sooner with interventions such as physical or occupational or speech therapy to support these infants and give them a better chance at thriving. This approach bridges the gap between feeding difficulties and developmental care, offering a roadmap for improving outcomes in preterm infants. Now, continued research is important in this field for the outcomes of preterm infants. There are four main areas where it is important and research will make a significant impact. And the first of those is in the assessment tools. Developing reliable and standardized tools is essential for early diagnosis and consistent monitoring. These tools would help early identify feeding difficulties and their effects before they would lead to more severe complications. The second is that research can also pinpoint which feeding and developmental interventions work best to support growth in neurodevelopment. Evidence-based practices will guide healthcare providers in making informed decisions. By understanding the long-term challenges that preterm infants face, researchers can design programs that anticipate these issues, reduce healthcare costs, and improve the overall quality of life. And the fourth and final area where research can make an impact is in strengthening support systems for families, caregivers, and healthcare providers by fostering collaboration, reducing stress, improving caregiver confidence, and ensuring better care for preterm infants. And in conclusion, providing comprehensive resources for families reduces anxiety, it strengthens parent-child bonds, and tailored interventions for children enhance growth, development, and quality of life. Advancing research and strategies within healthcare systems ensures lasting improvements in preterm infant care. Ultimately, prioritizing research and care for preterm infants addresses the immediate challenges while also paving the way for the future of these preterm infants, where they can thrive and reach their fullest potential. I would like to say thank you to my professors and everyone who has supported me throughout all of my years, but of course, primarily the Lord, just for all the blessings that He's given me and just getting me through college. So yes, thank you guys. Any questions?
So will the feeding changes be different with like the type of births? Like if it was like a C-section, like a vaginal birth, could those look different?
Yes, for sure. Oftentimes how it all really relates to how early the infant is born. So not as much relates to which type of birth it is, but really how early they're born.
So I don't think that I saw any delimitations listed. Would you also be looking at multiple births and how, since multiple births tend to be premature?
Meaning like twins,
triplets,
yes,
quadruplets.
yes, for sure.
So they could still be included. You wouldn't separate those out.
Correct. Yes. Yeah.
So I do have a question, and I guess it's kind of related to both of those other questions. Was it the study you're proposing is basically just to look at babies who have difficulty, or is there a gestational week time, cutoff time that you would think most of your experimental group would fall into? Do you know what I'm saying? Like if anything before 37 weeks, is that what you said, is considered preterm, but there were differences even on your slide between 37 weeks or 36 weeks and 20 weeks. You know, well, obviously 20 weeks, it's very life-threatening, but you know what I'm saying? But there are babies. I have a great niece who was born to 20 weeks and she's fine now. She's 7. But
different challenges are all for the different preterm. So as long in this.
So were you just looking at all of that? Okay.
Specifically,
Because that's a very wide range of
it is, yeah.
from a mild feeding, what I would assume is a mild feeding issue
I just
to
looked at all preterm births, which really is just before 37 weeks. Yeah.
And
Okay.
no, go ahead. Was there any consideration to the feeding, the developmental delays relating to what were they fed with? Was it breast milk or formula at the when feeding was being introduced? Right, so they were tube feeding them, but then they showed in the picture that they are trying to get the baby to bottle feed.
So tube feeding comes first, and that's with formulas.
Okay.
But then when they're initially transitioned into bottle feeding, that's also formula as well. But
So-
breastfeeding is the goal.
Right, so because I wonder if there were any of those delays that could have been, or better health issues with children who were breastfed versus, I mean, obviously with the bottle, but using breast milk rather than that. Initially, they probably do because it's the concentration, I'm sure, is why they tube feed with heavy concentrations.
Yeah.
And I had one last one because as you were reading this, I've seen time and time again now that we're seeing more and more things studied this way. Did you give any consideration to doing, since it is a retro study, doing an AI analysis, using it to pull out the data that you're looking for? I would think it would be pretty quick to find that information out.
Yeah, I did not, but that, yeah.
Yeah, because a lot of the retro studies where they're looking back, they're starting to see that even in diagnosing and things, when they put that data into AI, it extracts the trends and patterns, which is what you're looking for, quickly. And they can then use that to predict.
Yeah. We do have, lots of water. That's for sure. That's a good thought.
And a lot of our discussion came out of policy. A lot of times policy dictates we have birth to 3, but we don't know what happens after 3 because there's not funding for interventions to kind of look at
Studies.
long-term effects and how that can impact policy and care. So, yeah. Thank you, Catherine. Any other questions? Oh.
So I know you mentioned it briefly in your discussion about how physical therapy can help with the. So did you ever find in your research what type of physical therapy the
I did more in terms of speech therapy. So physical therapy, not as much particularly. I can tell you more about speech therapy if you'd be interested in that, but yeah. So to answer your question, no, not about physical therapy, but speech therapists, starting off, right when the infant is born, it's speech therapists kind of help with holding it with teaching the parent how to hold the child, how to best allow them to feed, angles of allowing the child to feed. And then as they're growing into, once the child has been taught into feeding and they've kind of started and has been feeding, then it's teaching them oral motor exercises to be able to allow themselves to feed. So yeah, that's more what's done by the speech therapist, but physical therapists, I can't tell you that answer, but yes.
Thank you.